I'm Jane Mitchell, and I work at OHSU, and I've had the privilege of working with AF4Q. Actually, after I was hired to help reduce the readmissions of heart failure at OHSU, my boss brought me a packet and said, oh yeah, we signed up for this. This is the AF4Q, which has pretty much consumed my life since then. But actually, it's a good thing. It has been a great tool for us as a hospital to take a look, sort of step back first, do a root cause analysis, and figure out what kinds of issues we had as an institution. And at the very beginning, we ended up looking at 6 months of readmissions, which meant that yours truly pulled all those patients, and I looked through every record and documented why they had their readmissions. I actually went with patients and I shadowed their discharge. I think there were 7 of them, and I did different times of the day. It was an eye-opener for me. I was able to look at some of the issues. My favorite, when the patient goes to screensaver and the nurse is trying to get through her checklist because she's got to get the patient out the door, and we're trying to barrage them with all this information, and the family is numb to it all. So it was great for me just to say, okay, now we need to stop and back up a little bit. There's some basics that are not happening. So following that, what I did was we've looked at the education of the staff, our providers, like, do you know when the patient discharges, can we get this patient back in within a week? Is somebody going to get their lab? Do we know how they're going to get there? Just everybody sort of taking a step back and thinking of it from the patient perspective. And from the family perspective. Right now I go with the residents every week with different multidisciplinary rounds, and the beauty of my position is that I actually am with just the advanced heart failure, cardiology, internal medicine, and family practice, as well as our hospitalists. So I'm able to pretty much roam through the hospital and try to figure out what the issues are. Many of them are the same, but many times for different disciplines we have very different issues that need to be addressed separately. So we recently just did a 90-day action plan with quality. I work a lot with our quality department, and we looked at live core measures. Oh my goodness, that is a big labor-intensive endeavor. I don't know if anybody's thinking about it, but it's a lot of work. It was very informative. What happened is we figured out that we needed to push a little bit more for nursing education with the patients, with the whole impetus of day 1 that the patient has been admitted. We're going to start talking to them about heart failure. We're going to give them material that's written at 6th grade level. We're going to get out a scale, and we're going to see if they can actually step on it and see what the number is, because it really doesn't help me to send you home and tell you to weigh yourself if you can't see the scale. So we've had a lot of eye-opening experiences, and I've learned a lot from the different disciplines. And when I work with family practice, Kat and I have had many interactions with a particular patient. There's several of those with internal medicine and family practice that we just sort of have to formulate a plan for that patient of what's going to work for this particular individual. Risk assessments tools, I echo Devin's assessment that basically for me right now, I've tried many different models, and the Get With the Guidelines sent out the latest one, the CMS one. It was a nightmare. I would have patients that I would know would be coming back in, and their score is 22. I'm like, no, I don't think so. It's not 22. So it's all a learning experience, but the beauty of it is I think there's a lot of things that we can do for the patients that are really basic that could make a big difference. So then finally, we've integrated palliative care. I've used a lot of outpatient home health palliative care, and working with our inpatient palliative care group as well to sort of, when a patient comes in that's very complex, we get around the patient, decide with their family, what's your plan? What's our plan? What are we going to do for you? What's it going to look like when we're done? Because that whole compliance issue, does compliance mean I just don't understand what you want? So we've been doing that a lot too. So I think in summary, a lot of sort of different things that we've been doing at OHSU. Some things have worked, some things haven't. I do monthly data, and that's the beauty of the AF4Q, is I'll look in May, I'm like, what happened in May? I don't know, but the next month was great. So you can sort of see every single month, and we just finished July's submission. So I feel like I know pretty much what's going on in my hospital. It's labor intensive. It takes me a couple of days to pull through all those charts, but I can tell you why those patients readmit. And now we're just going back and looking at our last 6 months again, the readmissions, and see if there's anything that we could do differently. So it's been a great process, and lots of support from the AF4Q folks. So in conclusion, I think it's a big issue. It's complex, but there are certain things that are really, really simple that I think that we can go back to, like, do you take your medicines? Can you get to your doctor's appointment? Do you have a doctor's appointment? Are you eating? You know, what's your weight every day? Can you understand when you write down that weight and it's 10 pounds less? Do you know to call me? Because I think there are some issues like this that we're just overlooking for these patients. Thank you.
Simple issues. Kathy, can you tell us what's happening at Marquis?
So I'm here to represent the long-term care sector of our panel, and our company, we have 27 post-acute facilities in 5 states. We also have our own home health and home care company. So we see the continuum of care in many different settings in the Northwest. And I would tell you that we see ourselves as sometimes the stepchild to the healthcare system, kind of the, what's that? But we wanted to really take a look at this, and so what we did is, as a company, and I know many of my colleagues are following suit, is we took last year, we took all of our readmissions, hospital readmissions that came from our setting that were within the last 30 days, the first 30 days of care, and we took a look at about 23 different levers as to why did those particular patients go back into the hospital setting. We looked at things from starting with their name, their diagnosis, so we looked at the top 3 diagnoses. We looked at time of day, who were the nurses on staff, who was their physician, who was their specialist, what's their family dynamic, what's their payer source. We looked at both Medicare and managed care. We didn't narrow it just to the Medicare patients. And it was a very eye-opening experience for us to go through and look at all of those patients. What we also know is that the responsibility falls both directions. And as an industry, we need to take a look at how well-trained our staff are, what we're able to articulate back to the medical groups when we do have patients who have a need to go back into the hospital setting. What we know is that as we follow their care needs and we get into a bit of a crisis, more often than not, as the situation goes on, we pick up the phone and we call that physician. We give them a very limited scope of what has occurred, and the physician almost always says, send them to the ER. I think it's for many different reasons. They're not standing next to the bedside. They have a liability. It's an easy decision. Often they're an on-call physician. They're not even the primary care physician or the person. There's definitely not the hospitalist that discharged them, and or they're not the specialist. And so the easy answer is just to send them back. And so many of our bounce backs were simply related to that. We've deployed a few tools at our company to try to mitigate this. One is an Interact tool, which was a grant that was awarded back east to a group and is now being adopted all the way across the United States, whereby it's a workflow chart for nurses to say, this is a diagnosis, if this happens, then do this, then do that, and kind of an if-then scenario, a crosswalk of things to do, and then once you get to the bottom, it says call the physician, and be able to give the physician a quick summation of what's going on with that patient, and then they can make a better and more qualified decision. Also, what comes with that is our recognition that our nurses aren't always prepared to deal with the level of crisis that they are now seeing in the post-acute environment, and so we spent a lot of time doing education. So it might be, IV administration, it might be respiratory care, wound care management, all different types of care that we see in particular areas where our nurses are not schooled enough. CHF, we had one facility in particular that had a lot of CHF patients that were going back into the acute environment, and so we've spent a lot of time in that realm of education. We also have deployed electronic health record, and we are now electronic from the point of entry all the way to the point of discharge. For us, what we're really waiting for is that transparency amongst all of the healthcare providers, so we're very anxious to be able to link with Epic and to be able to link with physician clinics. If they want to be at home and log in, they can do that. If they're a hospice agency, if they're a home health agency, they are able to look into our system and be able to see the history of that patient, and that has definitely helped us to reduce the number of bounce backs in our environment. This is not a perfect study, and I think that's kind of been the theme of the day, but we are doing our level best to try to get our arms wrapped around what we can do to help prevent avoidable readmissions. On a bigger picture, I also serve on the Oregon Healthcare Association board, and we as a group were talking as an industry what we need to do to be prepared to work with all of you who are in the hospital and physician clinic settings to make sure that we can mitigate bounce backs, and then also at a national level from the American Healthcare Association. So it's definitely gotten our attention, and I think people are fast and furiously working to try to do what they can to help mitigate this.
Very good, thank you, Kathy. Dan?
I'm sorry.